All right. Shh. We're getting started here. Shh. Thank you. Okay. All right. What do you guys think of the study? Very recent, really profound results, huh? They're like, it didn't find anything. That's okay. Is that useful information? Absolutely. Still can't be useful information. So let's go through it. Let's see what we think. All right. So the first question we're going to be asking about is what's the hypothesis here? So let's go to our random number generator. Would it really mess you up if I like re-randomized the Excel sheet to like so you don't know what your number is? Add a little bit more. That's okay. Let's do 57. Should be Miss Lauren Davis. All right. Thank you for standing up. So, what was the hypothesis for this study? Say it. Yeah, you can speak up a little bit.
Yeah, no difference in the risk of cancer or cardiovascular disease with supplementation of vitamin D.
So, is that their hypothesis or is that the null hypothesis? Okay, so that was the null saying there's no difference supplementing vitamin D in cardiovascular events or cancer. Okay, so then their hypothesis would be. And what difference were they trying to show?
It would reduce the risk.
Right, yeah, so you want to say they're not trying to show that vitamin D is harmful, right? Because you probably wouldn't really want to run a study saying that, this is actually cause more cancer and cardiovascular death, right? It wouldn't be too ethical. But yeah, so they're hoping to lower it is what they're looking for there. That can be important too, especially if you don't know if it's going to go one way versus the other. That's where you can do things like two-tailed tests versus one-tailed test. That can play a role in your statistical testing. Thank you. You said no. So let's ask about, this is a big one, so we might need a couple people to help me out with this one. So what is the design of the study? All right, number 5. Number 5 is alive. Let's see. Miss Chelsea. And again, I'm very sorry if the randomness picks you more than once, but it truly is random. Anyway, so what do you think about the study design?
It was randomized and it was a placebo-controlled trial of double-blind study.
Okay, so first off, is randomized. What does that mean? What's random?
Who gets the placebo and who gets the...
Yeah, what group people get assigned to, right? So whether they get placebo or they get the active drug. Okay, so good. That's the randomized into which groups they get. What does the double-blind portion means? Who doesn't know what they're getting? The patient doesn't know. That's a single blind where the patient does not know what they're getting. And then the double blind is what? The experimenters don't know what they're getting. Now, does that mean that you give it to them and then you're like, I don't know, I guess we'll never know? There's usually an unblinded person, right? There's usually at least a few people who are privy to that information, and they will know whether the patient or randomized, which group they actually got into. Good, so there's that. And then placebo control just means what? Yeah, so one group will get placebo, and then the other group will get active drug. What is the benefit of doing a placebo-controlled trial? Yeah, to actually see if it has an effect, right? Because again, placebo effect is a real thing, right? Mind over matter in a lot of these cases where I can give you a sugar pill and say this will really fix your blood pressure. There's some people who actually will respond to that, right? Especially if they had anxiety about it. All of a sudden their anxiety's gone and things like that. So placebo effect, you want to be able to account for that, right? So you can make a good comparison and say vitamin D definitely did this. This omega-3 fatty acid definitely did this. All right, thank you. You sit down. The blinding is actually really kind of interesting because again, if you were a participant in a trial, would you want to know what arm you were in?
Sorry, just recapping.
Yeah.
Like the one, you said the experimenter doesn't know, but it's both, right? Like it's the...
It'll be the patient doesn't know what they're getting, and then the experimenter does not know what they're getting, right? So that's double blind at that point, okay? But if you were a participant in this trial, would you want to know what you're getting? Yeah, I mean, people are just naturally curious. They definitely would want to know what they were getting. Am I getting actual drug or am I just getting placebo? If you got placebo, do you kind of feel a little gypped? I want the actual drug, right? I want to know what I'm getting. That's really important because actually in some of the studies that we do over at Nemours, we have one for, it's a relatively low incidence sort of disease called spinal muscular atrophy. And it's something where we are now doing experimental studies. We're actually using a drug administered intrathecally. And so we're running these trials. Now the drug's actually out on the market now, but we were doing this thing where some patients were getting placebo and some patients were getting active drug, but we still had to give those LPs to those patients, right? And so it's one of those things where you're like, well, that sounds kind of unethical. You're still having to do an LP, and so yes, but it's one of those things you have to kind of work through, especially when you have they talk about international or institutional review boards. Those are the people that actually say like this study's ethical, you may do it or not, whatever the case may be. But it was really kind of interesting because us from the pharmacy side, it was a double-blinded trial, so the patient didn't know what they were getting. And again, this is children, so the parents didn't know. The parents obviously they wanted to know. The providers didn't know what group the patients were in. However, the pharmacy staff, we did know, because we had to be able to make sure we gave them the active drug or not the active drug, as the case may be. And so it was really kind of interesting because like the family, they would be like looking at the syringe, be like, does that look like drug? Is it not drug? Can't really tell. And they kind of look at you and be like, what's the look on your face? Can I tell if you're giving me kind of a smile? Does that mean the patient's in the study or not? It's really kind of interesting because they really wanted to know. And so you had to like play it calm and cool, be like, here's the drug, just walk away, even though you know full well what they're getting. But you can't give it away, so you got to have like kind of your poker face on at all times. So it's kind of interesting when you get down to the blinding thing. So how do you think they blinded this study? What were the techniques? So a lot of times it has to do with like how the actual pills look, right? So with this case it's vitamin D and this omega-3 fatty acid. They have to make sure they look identical, right? So again, all the packaging. If one comes in a blue pill, guess what? The other one needs to be a blue pill too, because otherwise people will know potentially which one they're getting. So that's one of those things that there's a lot of techniques that go into the blinding. Because again, once you break that blinding, then all of a sudden the study results can be questioned, right? So again, it's one of those things that's really, really an important part of the actual study itself. Good. Okay, so it was a, let's see, placebo-controlled trial, randomized, double-blind, all very good. Patients were either getting vitamin D and the omega-3 fatty acid versus not, right? So next question up. What would be the independent variable, the dependent variable, and then what types of variables are these going to be? So let's go to number 28. Kim. Okay, so what would be, in this case, the independent variable?
Is the supplementation, well, it's vitamin D supplementation.
Yes, which group they got put into, right? So whether they got vitamin D and omega-3 fatty acid or not, right? Good. And what would be the dependent variables then?
It would be the incidence of invasive cancer or cardiovascular events.
Good. And so we'll talk about the different outcomes in a little bit, but there's going to be the primary outcomes and then secondary outcomes. So that's going to be important when we kind of get into the analysis of it in just a few minutes. Okay, so as a dependent, what would you consider the say like the rate of invasive cancers? Would you consider that to be ordinal, continuous, nominal?
It would be nominal.
Be nominal? So how do they actually classify it? So how do they actually count the?
That's incident or not.
Yeah, so either they had the cancer or not. Yeah, absolutely. So you can consider it from that point to be nominal in that case there. Overall, though, when they're actually looking at the rates, they're actually looking at the incidence of cancer, that's going to be more of a continuous variable. And so that's why we can do some of the analysis that we are going to do a little bit later on. Thank you. You sit down. Very good. So that makes sense. Okay, so how are patients included or excluded from the trial, and then how do they get assigned to each group? So 33. Nick, I'm standing up, sir. So how do they include patients in this trial?
So they needed anybody, males over 50 years old, females over 55 years old. They wanted at least 5,000 Black participants. They wanted the Black participants because vitamin D absorption is different depending on skin color.
Why do they have men coming in at a younger age than females?
Cardiovascular risk for men is higher.
Yeah, at a younger age. Okay.
I guess I didn't actually see why, but I'm guessing it's why.
Yeah, so that is why. So yeah, when you realize that men tend to have heart attacks sooner, right? So again, they're more likely to have that cardiovascular risk at a younger age. So again, when you're looking at these things, you want to say that does this make sense? Like, does it make sense that they're including the different ages there? Because that could be a potential confound, right? It could be a potential adding in bias into the study there. So you always want to kind of question those.
I saw the mean age was 67, but I didn't see if there was a mean age for men versus women.
Okay, yeah, so that might be one thing you'd want to consider, like, okay, well, were the men skewing that much younger just because you had a potentially larger group of people to pull from? That's definitely a good question that you may find in things like the supplementary information if you wanted to dig that much deeper. But for our purposes, probably doesn't really matter a whole lot, but it's an interesting question for sure. Anything else they used? Okay.
Well, they had to have no prior history of cancer or cardiovascular disease, and I think they were screened in a questionnaire.
Okay, good. Yeah, so the screening the question, that's part of the exclusion criteria, right? So if you had any previous cancer, cardiovascular disease, then you got excluded out. Why do we do that?
Somebody has previous attack,
Exactly. Or they have cancer before, they may get cancer again, right? So absolutely. So again, you're trying to look for new incident cases of these diseases, not necessarily people who may be kind of recurrent, because that again could skew your data there. Very good. And then you may sit down. Thank you. Let's see. So any other particular exclusion criteria anyone noticed? You have a pretty good long list of it. So do you feel that it was, the exclusion criteria they used, was it too restrictive? Was it restrictive enough? What do you think? Because sometimes you want to look at it and be like, well, if they're so restrictive, you can't get enough patients in. However, we're going to find that the sample size here is not really going to be a problem because it was a very large study. But something you want to consider, like, was it too restrictive or does it make sense based off of these things? So again, I think a lot of these exclusion criteria do make sense, and so you can say, okay, that works. We can go with that. Now, what about, say, for instance, things like vitamin D supplementation? Were they looking at that? Yeah. So. Yeah, so they had to look at like outside sources, right? So again, you're looking at things like diet and whatnot. How are they tracking that? Yeah, they're following up questionnaires. People always tell the truth? Not necessarily, right? Are people going to, if I call you up and you're in a study and say, hey, you're taking all your pills? What are you going to say? Yeah. You look over and you got a whole bunch of them. You're like, I should probably start taking those. Or, for things like, how much vitamin D, how many units of vitamin D do you think you guys get in your normal diet in a given day? Ashley probably knows, but anyone else? Yeah, 800, do you think? Maybe? No one knows, right? Actually gone, unless you do MyFitnessPal, maybe you have a little bit better estimation there. But yeah, a lot of times it's one of those things where, if people's, especially older patients, and maybe forgetful, they may not think about these things. So again, a lot of it goes into what kind of survey are they doing, how closely are they following up people. And so they talk a little bit about adherence a little bit later on. That's, again, a very important aspect of this. Make sure patients were actually adherent to the thing you're, experimenting with. Very good. And if you look at the randomization, oftentimes they'll talk about how they randomize based on certain blocks, and they have all these different things here. So you see computer generated within sex, race, 5-year age groups in blocks of 8. That's just different patterns they use to try to randomize things, because again, truly random things are very rarely exist, or it's hard to do with computers because just the inherent nature of it, there's a little bit of bias there. So they try to do every technique they can to make sure that the groups are truly randomly assigned as best they can. So that's kind of what they're talking about there. Okay, so now getting into the outcome measures of the study. So what were we actually looking at? And this is going to be important. We're talking about this. Now let's get 31. All right, Samantha. So, what were the outcomes?
So they were trying to figure out whether or not people had cancer or the cardiovascular event. They used questionnaires, I believe, to figure out that.
What do they consider to be a cardiovascular event?
Like MI, stroke, or death related to cardiovascular.
Yeah, so again, that's one of those things where sometimes they talk about all-cause mortality or like all cardiovascular death. So sometimes they'll lump different outcomes together into one. So it's important to know what gets included in those outcomes, right?
I think they also used the questionnaires to figure out whether or not they were compliant with the vitamin D.
Mm-hmm.
They used blood samples to measure vitamin D and at baseline and follow-up. See how much was in their blood.
What could you use that information for? Well, for instance, you could use a marker of adherence. If their vitamin D levels didn't change at all, they may not be taking it. I'll note they didn't really include a lot of the information as far as vitamin D levels and the actual primary outcomes. Because what you mentioned so far, the cancer incidents and then also the cardiovascular death, that was the primary outcomes. Okay, so they had a whole bunch of secondary outcomes. What were some of those?
I think it was just other cancers like breast cancer,
Mm-hmm.
cancer.
So you look at them like individually. They had things like, did they get undergo PCI? Have to have cabbage, things like that. So there's a lot of secondary outcomes. Thank you. Let me sit down. So note that when you're looking at the trial results here, they say, okay, here's our primary outcomes. That's the thing you should really be taking away from the study, whether or not they found any true differences there. And one of the big things I noted that you'll see here is that when they were looking at statistical analysis, what do you kind of notice about when they were talking about the different tests they were going to run and about all the secondary outcomes they were looking at? Anyone notice anything about? Because what happens if I could look at every single secondary outcome. I can say, okay, let's see how many people stubbed their toes during the study period. Let's see how many people forgot to take a dose. What happens if I keep running different comparisons over and over and over again? you're going to find something eventually, right? Because again, just due to random chance, like you can find statistically significant results, right? Because again, we're still using the alpha of 0.05. So because of that, how do we get around the multiple comparisons problem? What do we do? Right? Or things like the Bonferroni correction, where you'd actually say like, okay, well, let's do all these different analyses. We'll do, if we're doing 10 analyses, we're going to take that 0.05 divided by 10, and now they have to reach that lower number in order to be significant. What you'll notice here, as they say, is that results regarding however, they had no control for multiple hypothesis testing, no formal adjustments were made to the p-values or the confidence intervals. So that shows they just did the numbers and they just put it out there. So can you take a whole lot of stock in those values? And if they say this was significant, can you say that that is absolutely true? No, you want to take it with a little bit of a grain of salt and say, well, okay, well, I know they didn't adjust for it, so it could be a multiple comparison thing where they just happen to find this difference there. However, is that completely useless information? What could they do with that? Well, they could say, hey, this is really interesting. We found this one particular thing that was statistically significant. I don't know if it's a multiple comparisons issue or not, but let's do a whole new study on it. Right? Because when we actually get to the results, we're going to find there's a lot of stuff that wasn't significant. However, there was one particular thing that was. Maybe we could look at that in its own study. That could be what we call hypothesis generating, right? And so that can be sometimes useful to look at future studies as they go forward, right? So again, not completely useless, but you want to be able to make sure that you're taking that into account and saying, well, even though they did find this to be significant, I can't necessarily take that to the bank and say, yes, this absolutely applies to my patient. Let's give everyone vitamin D, right? That makes sense? So one thing you want to be considerate of there. Okay, so let's look at the results of the study itself. So let's look at some of the graphs here. Some of the tables, 44. Miss Ashley, standing up. So let's look at some of the results here. So we saw the randomization. Now, looking at just the demographics of the patients, is there anything kind of noticeable here? How many patients do we have?
Total 25,000.
Is that pretty good?
Yeah.
That's pretty good, right? It's a huge study, right? So again, in very expensive, very difficult to do. But again, this is why this is in the New England Journal of Medicine's journal, right? You know, this is a big deal. It's a big, kind of study. This is where they usually get published in these kind of big big journals. But yeah, so large in there. Now, looking at that, did you see anything about a power calculation? Yeah. So what was a power calculation? What does it help us do?
Determines how many people we need in the study to come up with statistical significance.
Perfect. Yeah. So it tells us how many people we need in order to achieve a certain effect size to actually show that difference there, right? So you can sit down for a second. I just wanted to mention that where they talked about it. Anyone knows where it's at off the top of their head? Right. So they said, okay, the trial was designed to have a greater than 85% power, and usually you shoot for like 80 in a lot of cases there, so that makes sense, to detect observed hazard ratios of 0.85 and 0.8, right? So again, they're looking for 15 and 20% reductions in those hazard ratios in those events there, right? So that means that they were powered, because they said this study was designed with power to show that difference there. So when they showed no statistically significant differences, as we'll see in a few minutes, that probably says that, yeah, there's probably actually no difference here because we had enough people to sufficiently show that, okay? Now, if I had a fewer number of people, say I only had 1,000 people and I showed no difference, what could I say? Say, well, the study's probably underpowered. It couldn't show that big of a difference, so again, we can't necessarily say that there's no difference there. What would you call it if you were to accidentally say, hey, there was a statistically significant difference, but there actually wasn't one? What do you call that type of error? That's a type 1 error, but in these cases, if you had an underpowered study, you cause what you call a type 2 error, right? Where you say there's no difference when actually there was one. You just maybe didn't have enough people to show that. So this study says, hey, we have enough people. We got a ton of people. We can say, yes, if there's any differences here, we're going to find it, basically, right? Good. So getting into back into the patient demographics here. Anyone notice anything interesting with the patient demographics? They look very similar to one another. Now, oftentimes what you can do is you look for significance here to see if any group was significantly different than the other one, right? So maybe, more African American patients got put into one group. Maybe more people with diabetes got put into a different group. And so basically what you can look for here, and you can look at the legend down at the bottom here, and it says, basically, there's no significant differences between the groups regarding their baseline characteristics. So that randomization was pretty good by having that many people out there that they're able to kind of cancel each other out as far as any differences go, and boom, the groups look very similar to one another. Is that a good thing, a bad thing? That's a good thing, right? You want your groups to look the same at baseline, so that way when I give one drug and one placebo, I go look to see what happens. I want those groups to be similar to one another, right? So that way if I ran the study again and I re-randomize all those people, I should get the same exact results, roughly speaking, okay? Anywho, so then getting down into the results here, so let's call on someone else. Number 14. Carson. Standing up. So what do you think about the results here, at least in the primary outcomes? There's lots of them, but what do they find? It's a little small. So how do we know that? So yeah, the numbers look similar, but can we say that whether something was statistically significant or not just by looking at that table? We can't tell significance based off the confidence interval? Yeah, we can. Okay, so good. So yeah, okay, good. So again, what number are we looking for it to cross to show that there's no significant difference? 1. Why is that? The ratio, right? It's a hazard ratio, right? So this is very similar. We were looking at like a risk ratio or an odds ratio, right? Because we're dividing one thing by another. If there's no difference, then it's 1, right? 10 divided by 10 is still 1. So yeah, so if you look through here, there's actually nothing that actually shows any statistical significance here, right? Because everything crosses 1, right? Now again, some of these may have trended towards significance. Some of them may have been very close, but none of them actually passed the muster, right? None of them actually were able to say, yes, we absolutely can show that this is statistically significant. So basically, what would your takeaway just a little off this table here? Right, so based off just this, we could say that vitamin D does not appear to reduce that risk of cancer or cardiovascular events, right? Good, thank you. How long do they follow the patients for? Yeah, so notice there that did every single patient get followed the same exact period of time? Now, one of the things you'll notice is there was an enrollment period where people can get involved in the study, and then there's usually a kind of a cutoff point. So some people got followed for longer, some people got followed for less, but it's good to look at that median period. It was about 5 years. So is that long enough to look to see if someone is going to develop cancer or a heart attack or stroke?
Not necessarily. They mentioned that as a limitation in their study.
Yeah, not necessarily, right? So again, maybe if I had run the study for 10 years, 15 years, 20 years, maybe you would actually find a difference there, right? So what would be a problem with running a study for a longer period of time? Compliance can go down over time. Expensive. You have more patients lost to follow-up. You have a host of other things that can happen there to make it very difficult. So again, the fact that it was even done for 5 years with 20-some-odd thousand patients, that's still a pretty monumental sort of task there, right? So a lot of people being followed for that long is still pretty good. However, you could say that, well, maybe if we'd followed this for longer, perhaps we might have seen an actual difference there. Okay. So again, is this information completely useless at this point? No. What if you have a patient that comes up and they're like, oh, I heard I should really take a bunch of vitamin D to help reduce the chance of a heart attack? You can say, yeah, it probably doesn't, right? You may need to take it for other reasons. Probably good. And again, this is higher dose vitamin D, right? They're taking 2,000 units a day versus normal, supplementation maybe like 400 units, right? So because of that, you can say, yeah, you probably don't need to kind of kill yourself with the vitamin D. Just normal supplementation is probably fine, because it does not appear that there's any kind of reduced risk here of developing one of these events. You can kind of see that again when you're looking at some of these tables here. Again, this shows basically cumulative incidence of the types of cancers they had or the cardiovascular events. Now, obviously, if one was much lower than the other, you'd see those lines diverge at a point. But if you notice here, they almost run parallel to one another the entire time. They're almost right on top of one another. So again, just showing you there's really not a big difference here between these groups, right? Now, notice, what do you kind of notice about the lines as you get further into the study? They're starting to pull away a little bit, right? So again, maybe if I had followed these patients for 10 years, maybe I would see a difference there. Hard to say, but again, based off the study just as it is, can't say necessarily there's any true differences there. Okay. Was there anything they found that was statistically significant? Anything at all? Not on this table. There's another table we saw something. There's one. Let's find it. Death from cancer, but what was the caveat? They excluded the first 2 years of follow-up and only follow from that later time period. So they did find a difference there. It looked to be the vitamin D was protective or harmful. It was protective because the odds ratio, the hazard ratio was less than 1, right? So it would show that the vitamin D is actually protective. That was statistically significant. So what could you take with that information? What should you do with it? I'll probably do another study, right? I'd probably take that and be like, okay, well, this is interesting. But again, because that was a secondary outcome, that's something they were doing post hoc. So if you ever see post hoc analysis, is usually the tests are running kind of after they do the primary one. And so again, the things you take with a grain of salt, it's interesting, but may not be the thing you want to take away from the study. They may be able to run something else afterwards and say, okay, we ran a different study, and actually do find that this actually is borne out when you do it for a long period of time or something like that. Okay. Let's see what else. And then getting into the limitations, what were the limitations of the study? Let's go to number 45. All right, it's Angela. What do you think were some of the limitations of the study?
So one of the limitations was that the mean duration of the follow-up was 5.3 years, which, as we said, may not be long enough to determine the long-term risk of developing cancer. Another limitation that we found was that the data was collected through questionnaires, and so the participants could falsify the answers. Also, if participants died, it was on the responsibility of their family to continue and give the results of their death.
Yeah. So it could be some loss of follow-up. Now, what do you call it when, anyone can answer this, when you have patients who maybe drop out of the study, but you still include that information in your analysis? So say the patient's in the study for, say, a year, and they're like, I don't want to do this anymore, and they drop out, and then you take that information forward. You call that? It's called intention to treat. So when you see intention to treat analysis, that means that people that who got that fell out of the study, either they just didn't want to do it, or they were lost to follow, that you still include that information, because again, if you were to censor that and say take it out, that could skew your data, right? So again, that's one of the things you want to look for, is like, was this intention to treat? If not, then you need to kind of look at that with a little bit of a wary eye to be like, okay, well, why were they falling out of the study? Was it due to side effects? Was it due to something else? A million different things it could be, right? I didn't tell you to sit down. I'm just kidding. You're fine. Good. So it was a big limitation there, right? But if you look at the adherence rate, what was the adherence rates that they determined? It was pretty high. I was just like, man, I can't believe they actually had that many people. That's the thing, is are they just saying they're taking it? Who can say, right? If someone called me up on the phone, like, you're taking your meds like you're supposed to, I'd be like, yeah, of course I am. But sometimes people are eager to please. But hopefully, by having that many patients, you kind of cancel the outliers out there and hopefully get a pretty accurate representation. But again, that could be a reason why you didn't find any difference if people weren't really taking it like they should have. So a lot of good questions there. Good. Any other questions about the study or anything you were like, oh, why did they do this, or what does this mean? Okay, let's do. You guys want to do like a 5-minute break and then we'll come back and then do the review? Let's do it. All right.